let's get started. I'd like to welcome everyone to Mississippi State Health, July meeting. We have members present, and Dr. Davis is this thing is participating digitally in front of us. To begin, I'd like for our Vice Chairman to give a prayer. Everyone, please stand, and then we'll do the Pledge of Allegiance.
Let's pray. Lord, just thank you that you've given us a new day, a day we've never seen, and we just praise you for that, and just thank you for this group and the people here, and just the dedication that we see in the Department of Health, and I just pray that you would guide us in our work, the decisions that are made, and just bless this group, and we just thank you and praise you for what all the ways that you showed that you love us, and just pray for the people that pray these things in Christ.
Amen. Now for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic which stands one nation under God, indivisible, with liberty and justice. Before we go on to the our agenda and approval minutes, I wanted to recognize Chairman Hob Ryan from the Senate, one of the champions of public health. Hob, would you like to say anything?
Dr. Edney wanted me to come and explain a provision of a bill, and I'll do that if you want me to, whenever you want me to.
Would you like him to do it now? Or would you like to?
Mr. Chairman, in our legislative report, we have a slide just related to the Board of Health Authority bill that incorporates all that language. It might be good to do it then.
Okay.
Thank you so much, sir.
I'll sit quiet.
And your presence, your presence is very appreciated and noticed. And your great leadership in the Senate is also very appreciated by this board. All right. First item on the agenda is the approval of our minutes. Has the board had a chance to review the minutes? Are there any corrections? If not, is there a motion to approve the minutes? There's a motion and a second. Without further discussion, all in favor say aye. Any opposed? All right. Dr. Edney, will you give us your report?
Yes, sir, Mr. Chairman. Thank you, and good morning, members of the Board of Health. Thank you for being here, and thank you for all that you do and helping us with our mission efforts. And I'm happy to be able to report out some good things for you. As you know, we always have challenges and opportunities. The majority of the report today is going to involve the legislative session, and then also a review of the state appropriation bill from this session. But as we get to that, just give you very quick updates from an epidemiological standpoint. Dr. Taylor assures me that there are no severe issues of concern outside the normal players at work out there in terms of infectious diseases. But we are continue to work with the Department of Agriculture with the highly pathogenic avian influenza issue that you're reading about. We still have no incidents of documented infection anywhere in our dairy herd or any cattle within the state, and certainly no human cases. From a national perspective, we've had the fourth human documented case. So the concern is that obviously these started off, this is avian influenza that jumped to cattle and now has jumped to humans. So the CDC is closely watching what's going on in the high impact states, mainly Texas, Kansas, Wisconsin. And so we're watching cautiously, but no activity in Mississippi thus far. The syphilis, and really it's epidemic at this point, is a top tier concern for us from an epidemiological standpoint. We have been working aggressively to improve our syphilis numbers, especially congenital syphilis. But now we have a significant new opportunity with some of our funding out in our appropriation this year. And and that was part of our ask, which I'll explain when we get to it. But some of the extra funding we received for population health outcome work is being invested into our syphilis work. And so Dr. Sutton, Victor, if you would stand, I think y'all all know Dr. Sutton. Dr. Sutton is chairing our new syphilis task force, which is pushing further ahead. We've had a work group in place working. Now we're really accelerating our work. And Victor's been given the charge to use our examples of all the wins that we were able to have during the pandemic. And by taking an equity approach and everything that we did with achieving vaccine equity, which eliminated health disparity that we were facing dead on at the beginning of the pandemic and obliterated that health disparity. So this is another situation that we're seeing a severe health disparity. So I've charged Victor to use the same approach to the SEAL project, and those board members who worked through the pandemic know exactly the approach that was taken. It was basically all hands on deck, working with the communities, listen to the communities, don't try to impose things, but to work cooperatively, collaboratively. And also, just from an equity standpoint, put the resources where they need to go in the way that they need to go. And that's what we're doing now that we have the resources. So we've identified our most severely impacted counties, and for your education, that's Hines, Rankin area, the Jones Forest area, and there's more going on when we see Hines and Rankin, not just Hines, but Hines and Rankin. We don't see just Forest, but we see Forest and Johns. That's more than a university phenomenon. And the only way we're going to get to the bottom of this is to be in the community and evaluating each community of what's going on. Why is Jones County having so much trouble?
And those are more urban areas out of our state.
And yes,
It seems to be having.
it's definitely the population centers, but then also DeSoto County and Harrison County, Gulf Coast area, and then Lauderdale is a significant area of concern, and we're continuing our good work statewide, but we're putting intense focus on these top 5 areas, because as we are able to turn the temperature down with syphilis and reduce our congenital syphilis cases in these top 5 areas, it's going to move the needle a very large amount for the state. The forecasting for syphilis is looking favorable for 2024, but nothing that we can report out. But I'm very optimistic that we will get this tamped back down to the way it should be. I'm very grateful for legislative attention to help us do this. You'll be hearing more about that. If everybody that's working with Victor on the task force, that's part of the executive team, stand, or that's what the board to see. And if you know where everybody, and there are others not here, thank y'all. That it's it's a
Smart group.
It isn't. You notice I didn't stand. But it's also a diverse group that covers many areas of jurisdiction, and they are all there because the work they do can help impact this population health outcome. And this is what worked in COVID, and it is making sure we don't have a siloed approach to this problem or any of the population health problems that we're facing. And we will keep you appraised as we move forward. Just a quick update on the District 7 demonstration project in terms of our new model for community level public health. Y'all, I believe y'all have y'all met Dr. Renee Dotson. Renee, would you stand? Dr. Dotson is our new director for our brand new Center for the Transformation of Public Health. And she has a very heavy lift, and that is to reorganize how we do clinical operation statewide in a manner that is more effective in terms of providing access to core public health services, and also do it much more efficiently. And it's extremely important is that it is done cost effectively. And she is doing a great job. Thank you, Renee. I had reported to y'all that we had started in District 7, which is Southwest Mississippi, and working with those 9 counties with the new model. We've learned a lot. We're not finished, but and I went last week down and visited 5 of the counties that we're working with, and talked to the staff and was able to see exactly from a boots on the ground perspective how it's looking in those little counties, and learned a lot. Had some really good ideas from the staff that were shared, and definitely changed my perspective on the approach to the smaller counties. And if we are really just putting every idea on the table, we know what to do with the larger counties. The level 3 super clinics that I've been talking to y'all about, that's working. That model works, and we're already going to be pushing that out statewide. And what a level 3 super clinic means is that these are public health clinics that will be open 5 days a week, providing all services every day with a provider present every day. And that is a game changer in public health. And in the past, we have employed about 12 nurse practitioners statewide. With the new models, we will be employing more like 20 to 30. And with us doing appropriate billing and collections with a much improved revenue cycle, though, the providers will help generate resources for public health instead of being cost centers for public health. So it's, this is, if those of us in healthcare know when you're adding providers, you expect those providers to cover their overhead and then some. Because, you're not adding to overhead with your providers, you're adding revenue. And that will be our goal. We're going to expand out initially to probably 20 statewide, and then I expect we'll need to get to 30 at some point, and then we'll go from there in terms of need. And we're still studying, Renee's team, Dr. Dotson's team, studying the medium-sized counties and the smaller counties. And have several models that they're working with, and I suspect we probably will be employing different models in different regions once the counties get smaller. Now, the larger counties, I think we have a fairly effective model, and then just working out what to do with the medium and smaller counties. Still trying very, very hard to keep the smaller counties open 5 days a week. That's the challenge.
One thing that's been real impressive about how he's handling this reinvention, this remodeling, is he's going there to the sites, and he's going to the counties, and he's looking at the needs, the individual needs. And one thing he's told me in our weekly meetings is he often changes his perspective about how to approach the situation. So, I think that's an extraordinary thing you're doing, and that's the way to handle it. Boots on the ground.
Thank you. And for me, the most important metric that tells me really overhead need is the cost per patient per visit, and that there are so many factors for that. And one big factor is the county appropriation. Just in District 7, we have counties that their appropriation is $10,000, and that costs $40 million a year to run the clinic. Another county the same size, $56,000. Significant order of magnitude more. And then you get to counties like Adams County where it's 160,000 or so. So it's that county appropriation impacts that number, the patient numbers, and I tell the county clinics, you're not judged on the revenue you generate in terms of having patients with insurance as the patients. How many patients are you seeing? You get just as much, if not more credit for seeing the uninsured as you do those payer source. Then it's our job, to build and collect those who have a payer source. That's a big impact. If you're not seeing very many patients, that makes the cost per patient go up. And so getting your patient numbers up, however we need to do that, will reduce that cost. Generating more revenue, billing for the work we're doing and doing a better job collecting will reduce that number. And all this working together to come up with what is the per patient per visit cost for public health. And for those of you in private healthcare, we have some counties where that figure is $500 per patient. That's expensive. So we've got to get those numbers down for the survivability of those clinics. But then I'm also looking at the counties where that number is high. And like I looked at Franklin County, and it was my first opportunity to go to Butte, Mississippi. I'd always seen it on the public broadcasting that they had a tower there, but I'd never been to Butte. But that's where Franklin County Health Department is. And it gave me the perspective that we're practically the only game in town. Now, there is no FQHC, Franklin County. There's one small rural health clinic and us. And so the challenge to the staff is, it's obvious they need us. We got to make sure that the doors are open, the lights are on, and they have access to us. And they're all very motivated to engage the community at a higher level and increase the patient count. So counties like Wilkinson and Franklin, we're and I'm willing to pay more per patient. But Mid-County has strong FQHC, a couple of rural health clinics. That's a different situation. So we just have to, as we move forward, make these decisions really, region by region. So I get a little taste of what Dr. Dotson is having to deal with within her center and for the transformation of public health.
It also goes to show how different rural communities are and
Yes.
how different the needs. And there's some rural communities that actually have vibrant communities, and there's others that are impoverished, from a health perspective.
Yes, sir. So one thing that we are doing, Dr. Gillison with the Center for Population and Rural Health and Dr. Dotson both have been instructed to develop a heat map for us looking at access deserts where every county except Issaquah have a county health department, and Benton is going to have sister counties. So we will be looking at where's the intensity of need for public health, and this, where we see that high level intensity, we know we have to invest. But I can't invest like we've tried to, for the last 10 years. I can't invest what we have just everywhere. We just don't have enough resources. Now, I'll be honest, there's some areas of the state where we have good coverage, where we can be of assistance to the FQHCs and rural health clinics, but we're not, we don't have to shoulder the whole burden. So as we're moving forward with this work and reporting back to you, that's, we're definitely seeing light and hope. And I am more optimistic today than I was 3 months ago. Any questions on that, Mr. Chairman?
Any questions?
I have two. Yes, sir.
I mean, you were saying $500 per patient, and that's not sustainable. You look at CPT codes, RVU, et cetera, there's no CPT code that comes anywhere close to $500. So that's a big gap there.
At least not the Z code.
Even with the Z codes, social determinant health codes. And then compare that to a super clinic, Adams County, where that per patient per visit cost is probably going to be more like $90. Very doable. Actually, it's a lane out there. But these are numbers I just did not have, until the last 2 years. And really, with the good work of Renee's team, we're drilling down. We haven't drilled through some concrete, but we're drilling down to see, what's what out there, really how of how things are operating and how they need to operate. And then we're out, I think a very important question is what do we not need to be doing? Not just what should we be doing, but let's concentrate our efforts where the need is and where our expertise is. And that will involve community health workers. There's no way around it. Franklin County and Wilkinson County, it does us no good being open if people don't know what we're doing and are struggling to get there and don't know about the transportation program, don't know about our telehealth resources. Yeah, I learned some great history that we came to the health department under Dr. Cobb. Dr. Cobb was looking for it. Was big drew people to the health department, and then when they got there, they were well taken care of. Our FQHC partners are experts and incentivize folks to come to care, and Frank, so we've got to do the same thing. Got to look what it takes to help people come to care, how they need to care. Let's make this investment. We need a return on that investment. Community health workers will be a part of it. Mr. Perry. Yes, sir. Pilot reimbursement and populations generally coming to health services. In past meetings, conversation, those two health departments being a place where we could also be working with other state agencies like insurance. The open enrollment period comes for the exchange. How's that process going in an effort to try to get, and especially that population of 100% poverty less, that can get at no cost on the exchange, getting them enrolled? A, they'll have health insurance. B, when they come to us, we'll get reimbursed, right? So many test both ways. How is that effort ongoing? I know there was a conversation with the insurance department as to whether or not we would have to be designated an insurance agent. Sure. Yes, sir. It's one of Dr. Dotson's many assignments in the Transformation Center. Part of Transformation Public Health is paying for the thing. And one of their assignments that they are actually working on is eligibility determination across the board and assistance with the program. Dr. Dodson is working out, I think, an effective game plan comprehensively for all of our major health centers, all medium and large, where it can be an access point for eligibility determination and enrollment that private providers could refer into us. Well, to for now, if they do, like presumptive eligibility, like all that we serve. Dr. Johnson, I think, has a good game plan to make sure that everybody that's eligible for Medicaid is up. They've been working much better family planning for family planning services, making sure that those who weren't eligible for Medicaid, but they're eligible for family planning, that goes in. And the heavier lift is marketplace, but I think it's imperative that we do it. And what I think will happen, Mr. Perry, is we'll go through the time, energy, and expense to get them enrolled and active, and then we'll get them into a medical, which is the best outcome.
Well, since as I understand it, the open enrollment period, I think, is in November.
Yes, sir.
But would it be possible that at our October board meeting, we could get an update or a presentation as to what we're doing with the various other agencies to try to be a part of driving that enrollment into the marketplace in November?
We can. And right now, I'm not seeing any barriers to us just doing the work. And because as I shared with y'all, our uninsured numbers in the public health clinics have been running about 40%. And, we know the challenge that hospitals have dealing with 10, 12% uninsured rates. We're dealing with 40%. So that we've got to squeeze that number. I know that out of that population, a significant percentage are eligible benefits that they just haven't been enrolled.
Right, and especially with the IRA subsidies, I mean, I should, the up to 400% of poverty, I mean, it's a pretty significant, effectively,
Absolutely. Range. So I don't know how much we can compress that number because just by the nature of our work, we're always going to have the highest level uninsured population, but that's our duty. But it just makes no sense to me to ignore some low hanging fruit that's right there that could be to the absolute benefit of the patient and also benefit to public health. You know, it's a game changer when someone goes from being uninsured to insured, and you actually, and then, you know, then our job is to get them get them in front of the Dr. Lampton, you know, and get them settled where they get all their comprehensive work done. And then we still are there for public health support, you know, as needed. But I think we'll see a lot of that enrollment, move to another provider. Not that we don't want to take care of them, but we're not the best home for them.
Can we put that on the October agenda, given the November deadline? Which they had to just be nice to know what we're.
And we had just, Chris has Experian gone live, or Dr. Dodson has Experian gone live yet? Okay, we've invested in the software that we'll be using statewide, but that when someone comes to the health department, we can screen what their current active state with insurance is. That just with one program, it will tell us if they're already active with Medicaid or active with Ambetter or active with Blue Cross. And, you know, that's step one. Because a lot of times our folks aren't very transparent with us. And then we see that they're not active, then we proceed with eligibility determination and enrollment. That's appropriate.
Mr. Albert has a question.
Yes, sir. Revenue cycle lane. Have you had an opportunity to evaluate outsourcing that versus in-house?
Yes, sir. We're expecting our Forbes report. Sharon, how long?
I'm gonna call Vic this week, so by the next few weeks, we'll have a draft, the recommendation.
Yes, sir. Then the evaluation has been done and we're waiting on the final report, and we'll have, of course, that'll be available to any of y'all when you run it. We'll certainly have it for you for the October meeting. And I think we'll see some good opportunity out of that.
Very good. Any other questions? Mr. Moody, we were glad you got here.
Well,
You're essential.
I apologize for being late, but I had the pleasure of visiting with one of Flowood's finest for about 30 minutes out there this morning. So out of the line of about 7 cars, he pulled me out. You know? But anyway, that's just part of it. But you know, I'm glad to know that we're doing our best to try to promote the healthcare people getting into the insurance. And a lot of people don't realize how low the cost is. You know, I don't know how we would work with some of these small employees. But, you know, we got employees in our poultry operation and also in the rest of our poultry. And highest premium we're paying for one of our individuals is $19 a month. Several of them are $16 a month. You know, we just pay it for them because they're not going, you know, I don't know how we could impress on some of our smaller employees how cheap it is to get their employees covered with insurance, and they're gonna have to pay it themselves, because, you know, you can't depend on them to pay.
Well said. Dr. Davis, are you doing okay? You have any questions? All right. What else, Dr. Edney?
And then, just so y'all know that the highest priority Dr. Dodson have to work on in terms of eligibility issues is presumptive eligibility for Medicaid pregnancy, since we're one of the legislatively areas that to occur. So it will be an access point statewide for women to have eligibility to foundation, presumptively Medicaid. me working for the local providers. Big partners. Dr. Dotson's working with the division, and we are as far down the road as we can be with that.
Dr. Lampton, I'm fine, but thank you for checking in on me.
Oh,
Want to be sure we're doing okay.
Slow. And then, and in terms of just general stuff, Libby and Joy, also, if you would stand, Joy is the director for our OAID office of helping
Office Against Interpersonal Violence.
Office Against Interpersonal Violence. That's great. It's where the VOCA grant resides, and also the state funding for our domestic violence shelters and our child advocacy centers resides. I just want to highlight Joy and her team because the VOCA grant was moved to the health department and was a big reason why Dr. Dobbs recruited Chris over to run OAID, and it was in trouble. It was under corrective action at a serious level, and but as it was sent to us, and through Chris's good work and now Joy's good work, we moved from a program under corrective action from our federal partners to now a center of excellence where Joy's team, their model is being used for local work, right, Joy? So at the national level, Mississippi is being recognized as a model for this good work. And Joy is very proud and pleased and appreciate the good work that y'all are doing. So I just want you to know that anytime you're hearing any issues related to the VOCA grant or the domestic violence shelters, that indeed that group is getting national recognition, for which I'm very, very proud and pleased. Thank you. All right, Dr. Golson was going to present quickly the organizational structure for the new Mississippi Center. And Mr. Perry, I need y'all's help. We're trying to settle on the best name before we do a lot of branding, because it is indeed going to be a center that's looking at health comprehensively and not just rural health. And so as y'all have ideas before we settle on something, Chris and I have been kicking around the Mississippi Center for Rural and Population Health. Whatever, any ideas that you have, we need a name for the center that's going to demonstrate a comprehensive look at healthcare in Mississippi, especially with our new legislative assignment. But it currently has actively the Office for Rural Health, which is what y'all have been used to having at the health department. So now it's just one office within the center. The State Health Planning and Research Office is where the State Health Plan is. We will be building out that staff to have full attention to the work of the State Health Plan. And already what Jennifer and her team are doing is taking the State Health Plan as it is and molding the State Health Improvement Plan, which has been under performance improvement in a whole different office, and the Rural Health Plan, which has been in the Rural Health Office, and just integrating all of those plans into what will be the new State Health Plan that will incorporate all of the community needs assessments that have been coming out of the State Health Improvement Plan work, and all of the data research as we look at capacity statewide, as we look at access issues statewide, as we look at services statewide, all the things that have been of interest to y'all, that will, all that work will be done in the center and the State Health Planning and Research Office. And so the State Health Plan will have full attention. And as I shared at the governor's office yesterday, the State Health Plan needs to be and will become an instrument that will be of value to our decision makers, so that when the governor's team is looking at healthcare challenges, that they will have the resource that y'all want it to be, that y'all are directing it to be, so that people can go and get the answers they need as best as possible related to healthcare in Mississippi comprehensively. Y'all do know that's the heavy lift, that we can do this, and that we're already doing. The first step was to break CON away from it, as the HMA report recommended, and y'all wanted, and I fully agree. So CON is over with licensure. State health plan works is standing alone. And so the state health plan will no longer be a CON document. It will be a health planning and research document. And so that work will be ongoing. We will need some more consulting support to really help us as we're writing out the new state health plan. And we still need more community engagement, which I know the CON committee will be doing on the CON side, but I think we'll need to do some more community engagement related to state health plan work, and certainly we'll follow y'all's lead on that. And in the Office of Mississippi Physician Workforce is now with us as of July 1st, moved from UMC to the health department, and I had placed it in the Mississippi intern. So all of the OMPW work will be going on there, which makes a lot of sense to me. Also, Jennifer has moved the Office for Primary Care into that space, but state health plan and OMPW are both good examples of things that aren't just rural health. And then there will be a strong research component, and the center overall will be where I pivot very often, commonly with specific questions that I'm being answered. So far, I'm very pleased with Jennifer's ability to build out what we have. She was going to be here today, but fell ill this morning. So the state health plan work continues. We still have a lot to do, but the direction that we were given from the legislature is right in line with, I think, the Board of Health's vision for what the state health plan should be.
And the legislature moving the Office of Mississippi Physician Workforce to us, and you putting it in the Mississippi Center, it's really letting us focus on our strategic planning on healthcare workforce.
Absolutely.
And you know, this office is doing such a good job with physician workforce. The center can really start to look at perhaps other significant workforce needs in
Yes.
our system.
Yes, sir. Okay. Any questions?
I think we've just answered it, but so the legislature moved office, physician workforce stuff, so that,
Yes,
legislative.
Okay, legislative action. Yes, sir. Okay. Next slide. All right, Logan. We'll now go through the legislative session with you. As Logan's getting ready, I just want to share that I think it was a very successful session for public health. I'm very pleased how Public Health Authority was not only maintained, but actually that the authority was not expanded, but responsibilities were. I want to publicly thank Senator Hot Bryan and Representative Sam Creekmore, our two public health chairs. They were amazing partners through this. Very supportive of the Board of Health's legislative agenda, very supportive of the needs of the agency, and we're very cooperative and helpful as we were dealing with legislative challenges that would impact public health. And I just want to voice my appreciation for their strong support in the efforts of public health through this last session. So, Logan.
Thank you, Dr. And then thank you, Mr. Chairman and board. And I also want to say thank you, you, Mr. Moody. You are our sub-chair, committee chair for our legislative portion of the board. And I appreciate your leadership and direction this year. All right, I'm going to go ahead and start with this. These are the 4 items the board approved last October for the session. And I'm just going to go through these one by one first. First, it's the yearly uniform controlled substance law that the board is passed by the legislature to recommend every year to comply with the federal controlled substance law. As you see, all 10 recommendations were placed under schedule on state level. The next item is we had 2 state support requests this year. The first one was for the rural water revolving loan fund. This year we requested $7,670,600, and we received all of that match. So that'll generate a little over $38 million for loans to be given out across the state. And we also requested continuing funding for the Underwood building renovation that we're working on right now. And the legislature appropriated $4 billion for that. And the Thompson Lab has, I believe there's still renovation going on over there. And then we also had a repealer for the, this is just a repealer that comes up every few years, for, on bills typically, and for Harper Grace's law, this was the year. They extended it out to July 1 of 2027. And then I'm going to turn this over to you, Dr. Eddy. This is the powers and duties slide.
So the most important piece of legislation for Board of Health was your powers and duties reauthorization. And just watching kind of what's going on around the country, I was anxious to see how the session would go, and it went extremely well. The responsibility, the importance of the Board of Health was certainly endorsed by the legislature. No reductions were imposed, and in fact, responsibilities were expanded, and we had it listed for you here. And these responsibilities were directives to us. This came out of public health. Judge Bryan, I believe it came out of your committee first, and was adopted on the House side as well. But it's to continue doing everything that you're responsible for doing, plus specifically studying a few issues. The backup just a bit, and I think y'all know that there was legislation passed to reorganize all the state boards and to kind of conform them all and put them on a 4-year schedule. And Secretary Bryan, I'll defer to you in just a little bit, but your reauthorization bill specifically kept yours at 6 years, and also gave the governor some flexibility and appointments. And I think this component of the bill's language change actually is very helpful for the work of the Board of Health. But I think it makes it easier for the governor to make some appointments, and it kept your service terms at 6 years, and it keeps the state health officer service terms at 6 years. Secretary Bryan, did you want to make a comment about the Board of Health appointments, or how y'all were looking at that change at all?
Seems like we got a good board. I voted for every last one of them. Pretty good, I mean, considering at most, one of them is everybody.
Wait,
Well, I always like to be around Senator Bryan because he was probably the most liberal, member of the total legislature, so he made me look good. Made me look like a conservative.
but I did appreciate both public health chairs recognizing that the importance of the Board of Health, how special Board of Health is, the long history of the Board of Health. And as I said, look, if it's not broke, I'll try to fix it. Board of Health is not broke. And so I'm very pleased that basically this pull exempt y'all out of the reorganization of all the other boards. Next slide.
And there has been a historic attempt by the legislature and by public health leaders to keep the Board of Health from getting involved in the politics of the day.
Right.
And for us to be focused on our duties and protecting the citizens and being focused on science and healthcare. And I think, that's what a 6-year term is supposed to do. And that's what having us, our appointment process and how it works, and having us oversee the state health officer is supposed to depoliticize what we do and allow us to focus on our core duties, which is science.
Yes, sir. And here is the new language in terms of added responsibility. And let me just go through it with you. And then Secretary Brian, I would like for you to make comments in terms of your perspective, making sure that we are following legislative intent as we're moving forward. But it was, looking at studying the status of healthcare in Mississippi and charges you and state health officer to study the status of healthcare in its broadest sense throughout the state, which fits very nicely with the vision of the state health plan. And that it is to include access to care, cost of care, indigent care, providing health care to the incarcerated, which is a hot topic in the legislature last session, availability of healthcare workers, lifestyle choices, consequences of the healthcare facilities locating affluent and urban areas to the detriment of less affluent areas, small towns and rural areas, negative trends, opportunities to improve healthcare, such as greater coordination among state agencies, local governments, other entities which provide various types of healthcare, methods of increasing the healthcare workforce, methods to increase the location of healthcare facilities in distressed areas, rural areas, and small towns. That is the bill language that was, and that did not come, from Board of Health or us, but I'm very happy to take that on, which is really, as I said, lockstep with our vision for the state health plan. So, Secretary Brian, would you like to make comments?
Can I just talk from here?
Yes, or come right here.
Yes, and microphones are in the center, we'll pick you up.
Don't want to turn my back on Mr. Perry. Let me, I have much to say. I'm not going, the good news is I'm not going to say it, but since Representative Moody said I was the most liberal member of the legislature, I was just thinking, I've been endorsed by the National Rifle Association, sometimes with an 8+ rating, until these folks sort of went off the deep end the past few years. I was the author of the biggest tax cut in the history of the state. Last time I ran for election, I was endorsed by just about every business group that was in the business of endorsing people that if I'm what passes for a liberal, we're in trouble. I also want to say quickly that there were some recommendations the board made, particularly about certificates of need, that the legislature did not act on. That's not because we ignored your recommendations or don't care about your recommendations. This was the first term of a 4-year session. As the session developed, every time I turned around, yet some other committee from somewhere was doing some far-ranging thing just on the spur of the moment. They were moving the school for math and science. They were closing the W. They were throwing me out of the circuit and chancery court district that I'd been in my whole life. And that just sort of shell shock, which to me is the exact opposite of what we ought to be doing the first year. Secondly, I'm very excited about Mr. Creekmore being the chair of the House committee. I'll make it clear, Mr. Creekmore's folks are from Amory. His mama and daddy finished Amory High School. I have no idea what they're doing in New Albany. But Mr. Creekmore and I worked together on some mental health legislation previously. And I don't want to get him in trouble by saying this, but in the most general of terms, I think we're pretty much in sync with what we want to do and what we'd like to do. And I think we both think the state board of health probably knows more about this than we do, so we're interested in advice. But I hope to have several years for us to work together, because I think we're just interested in trying to improve public health. The specific thing that I was asked to talk about is the fault of an organization called the Milbank Memorial Fund, which was started some years ago to improve healthcare in New York, primarily by trying to get dead animals off the street and building bathhouses for those who are living in apartments with no running water. Well, things seem to have evolved over the years. And I guess the shortest way to describe the Milbank Institution is it's a think tank. But when Senator Nunley had to resign, Senator Nunley had to resign. Senator forced to resign. He was elected to Congress, but it sounds much more ominous if I say he was forced to resign. But he was nice enough to suggest that I participate in this group. This group, and Dr. Edney has been to some of their meetings, the people that show up are state health officers, cabinet secretaries, committee chairs from all over across the country. And people are just interested in healthcare, each drama or anything. And you learn a lot listening to people. One of the things that affected me was an individual from Michigan who was the state cabinet secretary for health. And this was when Rick Snyder was governor of Michigan. He says, when Republicans have the state, the governor, I'm the guy, and this would have his counterpart when the Democrats elect a governor, he's the cabinet person. But he said, when I talk to Governor Snyder, all they ever ask is what's best for Michigan. We don't talk about the merits or lack thereof, what they're doing in Washington or any of that. We just try to, given the options we have, what's best for Michigan, which stuck with me. And I sort of think that's the approach I take. I can't help what they do in Washington. But whenever we get through passing whatever they're going to pass up there, I think those of us in Mississippi don't look at it and say, okay, this is the world we live in. What can we do that's best for Mississippi? The other thing I got out of this meeting was the various ways states are organized. And it's understood the cabinet secretary, it was not the head of the State Department of Health, it was to look at healthcare statewide. And so I've had conversations with Dr. Edney about this over the years. And it seems to me that what was missing in the state was some specific entity, some person, some place that had the specific duty to look at healthcare comprehensively. If you look at the powers and duty of the State Department of Health, I guess probably have the ability to do that if you want to, but you don't have a specific task to do that. This is what I'm talking about. This is the example, or two examples. We have at the Department of Corrections a large number of elderly, sick people who are eligible for parole. It's a sad situation because there's no place for them to go. Their nearest relatives, cousins, whatever, aren't real excited about having their long lost cousin who's been in.
How you doing? How are you? Thank you.
Was guy.
All right, come back home to live with. And so they're in Parchman, it's expensive, they're getting improper care. And there's been a discussion over and over that one option would be to have a nursing home built for the purpose of taking care of inmates, though not so much specifically. But if that took place, then first of all, the individuals would get better and more appropriate care. But secondly, they would all become eligible for Medicaid once they were no longer in an institution. So the state would save money. Well, thinking more about that, the thought was we will put this out for bids because, you know, it'd be a money-making project. Meanwhile, in Greenwood, where there was once a comprehensive hospital, as way goes on to way, the hospital had more and more and more difficulty. And now there's some question of it being a rural emergency hospital, or whatever the term is. LaFleur County owns that hospital. But the implications of the hospital in Greenwood dramatically reducing its services goes far beyond the county floor. It's an issue statewide, but nobody had the responsibility to look at that. And so it was happening gradually, but nobody. So the thought is somebody somewhere ought to be looking at this and saying, you know, this isn't just the Board of Supervisors in LaFleur County. What can we do? Well, one thing that could take place is if such a nursing home for prisoners were to be built, it could have been built at Greenwood. And a certificate of need could have been granted to the Greenwood LaFleur Hospital, so that the Greenwood LaFleur Hospital would have some additional source of revenue from that facility, but B, there would also be a need for these individuals to go to the hospital periodically, and that would have helped support the existing hospital. Certainly that would not have solved all the problems of Greenwood LaFleur Hospital. But there are opportunities like that all over the place, and nobody's in charge. Nobody is supposed to be thinking day to day how to do this. So I think we need somebody somewhere that's got that task. And in talking to Dr. Edney, I said, well, it seems to me the logical place to put this is at the State Department of Health, because all the other options are even worse. And so that's how the legislation came about. And the purpose of this, I think it has great potential, is to have an office at the State Department of Health, whose job it is to look at healthcare for the whole state. Not the Department of Health, healthcare, everything, private, federal, state, whatever. What's out there? What are the problems? What can we do to it? And there's situations where you just need people thinking all this. I once had a professor at law school said, what do you pay a lawyer to do? Sit with his feet propped up on this desk and stare out the window. Well, yeah, sort of. You pay your lawyer to worry about you. And so this isn't people to sit around and think, be removed from reality, to the contrary. But the language in the bill, which is now the law, very specifically says the State Department of Health has this duty. And it very specifically says that every other entity in the state is to cooperate with the State Department of Health and to provide information to the State Department of Health. And it very explicitly says the State Department of Health can't make anybody do anything. So the thought is not that the State Department of Health is going to be running every agency and every other. But they do have the authority to get information, to go to the Department of Corrections, say, can we see this contract y'all have for private healthcare, for healthcare services for people at the Department of Corrections? How much are you paying? Can we get some information about that? Because there's a bunch of this money that I think is being spent inefficiently. A bunch of it's going out of state. And there are a lot of healthcare providers in this state that just plain need volume. And there are situations like this where everybody can wind up better off. But the Department of Health now has the authority and indeed the task to look at all this stuff. They can't make the Department of Corrections do anything except provide them with information. But we got some folks down the street who can make folks do stuff. And I believe that as the Department of Health, Board of Health make recommendations to us, all of us have a great respect for the board, confidence in the board, confidence in the department, confidence in the state health officer. Yeah, I think if you make suggestions to us, I doubt we're going to do every single thing you ask, but I bet we do an awful lot of things you recommend. So I really think this has potential. I'm very glad that y'all are willing to take it on. As I said last time I was here, this department has a history. it has a reputation. It's been a good, well-run department for decades. And we're all very fortunate to have that. I think this gives you an opportunity to continue what's been taking place in the past. Thank you.
Thank you, Mr. Chairman.
Yes, I hope y'all realize that Senator Brown and I have had a great working relationship over the time that I was there. And I can assure you now, there are some people in Mississippi today that are living a better quality of life because of what your Senator Hart Brown.
And Mr. Chairman,
And because
Wait,
this,
maybe.
I took this directive very positively as a sign of respect and trust in the board and the agency. And yeah, but again, it actually is a minority to our work with state health plan because this statute very clearly says all state agencies shall cooperate, including specifically pointed out DARE and ELPA are to cooperate. So we'll have resources through peer to help us with some of the research that we'll need to do. But now we have statute behind us as we're needing to get information from specific entities related to the state health plan, at least within state government. It'll be much easier for us. And I don't really see it as any additional burden other than what we had already decided to do through the state health plan. It worked. So I'm quite pleased with this. And I will tell you that throughout the session, the Board of Health's opinion was appreciated and respected throughout session. I was called many times with many questions unrelated to any of our legislation. And I think it relates to the trust and respect from this entity.
Well, I think this underscores the role that we as a board and the state health officer in our department must play in improving healthcare in the state. And I think, and the board needs to give strategy to the department about what we need to study and certainly our recommendations to the legislature.
So is it your vision that
Can you put that list of things back up?
so a number of those things, just you looked at the number of the statutory authorization of the state health plan previously, some of those things were in there, some are no, they're new for sure. Is the thought that this would be incorporated into the state health plan in an annual update, or is there a specific study, the date, time, delivery, or is it an ongoing thing? Is it a one-time thing? Like what is is there a specified deliverable beyond the state health plan? I don't know.
it's in perpetuity.
That's the assignment as I took it, Mr. Berry. And that, the other thing, yes, sir, because I mean, y'all see, yes, we will not have to complete it by January.
I guess if you're asking me what I thought, seriously, I don't have any specific expectation that somebody's going to deliver a report and say, here, this is it. And as far as what you recommend, how you recommend it, or when you recommend it, and that's up to y'all. I mean, my thought is that y'all know what you're doing. The department knows what it's doing. As you start collecting data and thinking, you'll have ideas and suggestions and share them with us as they come along. But I think it's sort of a rolling thing. I don't think it has a beginning or an ending.
That's helpful. I mean, it seems like the reading between the lines of what you're saying, Dr. Indy, it seems like a lot of this is the building on what we've been talking about with updating our approach to the state health plan that would be included in that document. And if that document is something that it's a living document that we're updating every year, well, it certainly would take, additional resources to be able to have the bandwidth to do that effectively. Is that your thought, or is that a premature? Is it too early to ask? That's exactly my thought. And I did hear Secretary Ryan talk about wanting to have an office doing this. That will need some funding.
But I'll work on that. But I think this is worthy work, and it just, what the opportunity we have now with both of our public health committees is they are wanting us to come in session and to present, you know, pretty much the state of public health. And this will allow us to perhaps at the beginning of session to, present the year's work to the two public health committees, that this is what we're seeing. We've never been asked to present about state health. But basically that's what we'll be doing, is that our yearly testimony, presenting the work to the state health plan. This is what we're seeing. This is, and that will be constantly ongoing.
And the legislature is asking us to have, in its broadest sense, and that's something I've said, and it's in there. But our view of healthcare needs to be in the broadest sense throughout the state. We need to be looking at everything. And we are the entity to do that.
Sorry, but that was one of my questions. And I agree, like, we need to look at the broadest sense, everything. And I heard you say that we would be allowed to ask the Department of Corrections for information, or we can go to another state health agency. But are we allowed to ask the private entities? Like, are we going to be allowed to go to Blue Cross and say, hey, we're working on this, help us understand some of the issues with your data, or blah, blah, blah? Where does that line sit between public and private? We're going to do that.
Yes, you can go ask Blue Cross Blue Shield questions.
Can you make them respond?
Oh, they're an insurance company.
That's
So I think
And I use them as an example because they are
the language, I think, is intentionally as broad as possible to try to both give you authority and give you guidance that, yes, look at everywhere.
Thank
The Blue Cross Blue Shield people have a lot of data and information about healthcare, putting aside all the payment issues and issues people may have right or wrong with Blue Cross Blue Shield, all of that. Apart from that, they just know stuff.
right.
I don't think we can, I know that we did not, I'm not sure that we can direct them to share that with you. One hopes that they would start making some things available. And maybe if there's a specific place to go to, that helps. But yeah,
Thank you.
Yeah,
I
ask
used them as
everybody
the
everything.
example because of familiarity, but I could have used Humana or Optum or, anybody else as the example.
the first place we would go is, the public information from those companies, those entities. And then if we're running into roadblocks that just, we don't have the authority to get past, we just share that with our legislative colleagues and see what solutions we can have. But that was going to be a challenge, with what we're wanting to do with state health plan regardless. And I think we'll see that as we move forward, what we're up against and how to maneuver with it.
I'd like to comment on something that Leigh was asking about, that there, I think this is a wonderful opportunity with a lot of, an amazing spectrum of issues, but data collection with almost every one of those items, I see as a problem, because people are going to throw up HIPAA and all kind of reasons why they don't turn over data, even if you're blinded to personal information. But at the same time, you've got to have that information to see whether what you are doing is working. So there has to be some way to obtain the data, and then there has to be, and ideally go into a collective database, which might present additional issues. But there's also got to be an opportunity or a way to retrieve that data, and we've had some issues with that with some of these data banks in the past. And so, I see that as a big hurdles that we're going to need to work and try and overcome.
Mr. Rudy, did you have a comment? Well, there's so many intricate parts of healthcare. I don't see one being able just to put together immediately one complete plan for the whole thing. I think we're gonna have to take it by parts. Mental health, long-term care, short-term care, and let those evolve over a period of time, not trying to put together everything at one time.
Well, sure, I think that's exactly right. I think it, yeah, I mean, these are such broad areas, you know, the correctional system, that's a massive undertaking in and of itself. All these others, I mean, whether you have, departments or divisions or bureaus or whatever, they're looking at those individual components. But there's separate, and it's gonna take different people with different areas of expertise, but it's gonna take a lot of collaboration across the state to make all this happen.
Well, and it's just like everything, healthcare is just like everything else. It's a never evolving process. You know, daycare, that kind of stuff. Years ago, we didn't even think about adult daycare and those kind of things. They come along and then, it's long-term care is, I can see being less and less important than things like intermediate care and those things are more, you know, need to be looked at closer than like some of the other things. But
What I think we'd all like to see is that, you know, we know, we've got a lot of data points on where we are. Look at that, and then we'll take 10 years to come back and say, this is what we did, this is where we now are. Look at the difference, and, you know, perhaps become a model for other states, but it's a huge undertaking, but you can't do it without being able to collect and retrieve the data.
you know, I'm just in my particular area, I see a more need for assisted living. I mean, but there are people on the list I know that's been on it for about a year or more, or trying to get into an assisted living facility. And the all of that.
Dr. Waits, did you have a comment?
Yeah, so this is monumental, and I personally am very pleased to see what Senator Bryan is presenting to us here. I have the question about CON and our state health plan. Was there much discussion in the legislature about separating the CON from state health plan, or are they having much push about getting rid of CON? Just give us some idea about that. But we're going to. Okay. Okay. We got a slide for that. I do want to make sure that you heard the most important comment he made, that this is a well-run agency. Yeah, I'm just making sure. For the most important comment, this is a well-run agency.
I think he said historically it was a well.
Thank you.
It's almost taken out of context, wasn't it?
Would Chair entertain a motion to have Senator Bryant come every session for both insight and motivation, as well as
Let's not get carried away.
I think I'm already supposed to do that.
He has an invitation.
I do want the board to understand that y'all get the size of the task, which means I have to step up. This is going to cost money. It's the money well spent. And it's my job to get the money and manage it, but this is not going to be a one-person operation. Dr. Golson has job security for sure with this, but and I don't know how large the team will need to be just for that one office, but it'll have significant support.
Yes.
Do we know if other states have offices like this that we could at least use as kind of a blueprint? Okay.
All right. That was a vigorous conversation. Anything else? Any other questions? If not, Logan, keep going.
Sir. Oh, if this was a bill that was requested by the department, in reference to the fact that this department currently operates in deficit, we requested from the legislature the ability to raise fees to make up some of that deficit. And what this bill will do, when it will allow us to adopt the NRC fee schedule, it will also give us the option to raise fees 2 times if we choose over the next 4 years, 25% each time. And Dr. I know you wanted to comment.
Yeah, this is an example where things will pop on the radar, very quickly. that our radiation health work has been, came to my attention and been running at a severe deficit, severe, and which means we're having to augment with state funding, and those dollars are precious for operating this agency. And it's fee driven, which means legislative intent is that the fee should cover the regulatory cost. We have some fees that are under your authority, then we have some fees that are under statute. This was a statutory fee, so we had to have the legislature approve the fee increase. When we run into these situations, I pivot, to the chair of the board and chair of the legislative committee, and they, this was something that really no brainer we had to do. Had great support from both public health committees, and it's on your agenda today for the first increase, which won't get us out of the hole, but will help a lot. And then we'll have the ability to do another 25% increase within this 4-year period, but that's as much as we can do. So we can't just adjust the fees ourselves. The legislature has given you the authority to review with us a fee increase to a maximum of 25% increases. This is also very much recommended by the NRC. They basically told us we had to get our fee schedule changed. So we appreciate the support that we had at the legislature for this. This was approved. That would be one of your action items.
I know we talked about this earlier. If we want, Dr. Neal, to go back over the slide, we discussed this in your opening statements regarding to the physician workforce.
Does anybody have any questions about OMPW moving over to us? The only, the downside, there was a significant amount of money that had not been spent, and by the time it comes to us, the unspent money that had been appropriated has to go back. So we got the new appropriation for this fiscal year. It was about $3 million that had to go back, and I'll be working with our appropriation chairs to see what we can do to try to get some of that funding for the office back, which is used for the community residency program. But we're actively searching for a new director for OMPW. Dr. Lampson serves as chair of the advisory board. Everything as it was happening at UMC, it's just moved into the center, the Mississippi Center, and is continuing. We're getting Dr. John Mitchell, who retired on contract to serve as interim director as we're doing the search for a permanent director. And that would provide some stability to the transition, I think. Any questions?
I think it's going to be a good fit. And I think the legislative intent is for this to get the department really focused on workforce issues in the state. And the success of this office really lays the groundwork for us to begin that work.
Yes. Okay. Excellent. Dr. Beaver. And then, we've talked a lot about EMS, and when I was meeting with the governor's team yesterday on the EMS issues, first thing he did was, tell the governor, thank you for appointing Dr. Carlton to the Board of Health, which is, Dr. Carlton's been a great help to me as we've been working through issues with MSAC and then issues in the legislature. These were not agency bills, but these were bills that were impactful to areas of our jurisdiction. And then we had one assignment that came to us. But really, there was a lot of attention to EMS cessation. We were involved a lot with advocacy and testimony. My advocacy was about EMS, the system itself, and raising the awareness, like we did with hospitals last year, raising the awareness as we have here at the Board of Health regarding the need to look at the issues with EMS, and the legislature did pay particular attention. The House Bill 1489, triage, treat, transport to alternative destination, was a big win for the EMS community. Currently EMS, as I've shared with you, is viewed as transportation and is funded as transportation. We look at it as healthcare, and when they were going to a home, rendering aid, oftentimes, getting a blood sugar up or reversing an overdose or whatever they were doing, the patient would get better, then refuse to go in. If they didn't go to the ER, then they did not get paid for that run, despite the costs that were incurred, the treatment that was provided, and and improved outcome. So 1489 looks at it more as healthcare, where they're able to treat in place and be able to be reimbursed. And so that is a big win. It doesn't impact our work, but we were supported because it was one of the problem areas that we were seeing in the system. And then also going to alternative destination sites, that makes a big deal to help take some stress off the system, because previously all runs had to be to emergency departments. And there are some rides that under that regional medical sector that there are better sites. It may be crisis stabilization unit, or it could be, the bill even looked at the need, oftentimes just going to an urgent care center instead of emergency department. That takes stress off, Dr. Carlton's ER, but it also takes stress off the EMS system, not to have to take them to the ER to turn around and take them somewhere else. So those were very good wins. There was also language that increased reimbursement rates in general. Again, these were not our bills, but were very important to the work that we're doing. Mutual aid agreements, Dr. Carlton, you want to?
This is such a common sense thing. And in reality, when I was medical director of the largest CMS district in the state, I required all of my ambulance services to have mutual aid agreements with continuous services. I did not really realize that it was not a statewide issue. But this now makes it a statewide issue. So, think about it. We have a lot of counties with only one or two ambulances, and the ambulance is dispatched to a 911 call. Well, it's not in service for anybody else that might call 911 at that time, or they get transferred. They get involved transferring a patient, say, to Jackson from somewhere in the Delta or wherever. So the county is either uncovered or relatively uncovered. And I've seen lawsuits where there are really bad outcomes as a result of that. This will help with that. So that when an ambulance goes into service, because of the mutual aid agreements, a service in a contiguous county typically pulls to a common point where they can respond to either county. So, I mean, it's like I said, it's a common sense thing, just had never been done. So I'm grateful to the legislature for doing that.
What is it for the legislature?
Because each county is like its own little fiefdom. And sometimes you have an EMS service that maybe operates along or within several counties, some of which are contiguous. But if they are not, there's no real obligation, because each service operating in that county typically has a contract with the county board of supervisors to have a response time of X, 8 minutes, 10 minutes, whatever it might be. And so if they are over in another county, even if they got one ambulance still in that county, their response times may go down depending on where that call comes from.
So is it that counties could have made these agreements themselves and just didn't?
And some work.
Okay.
And but this mandates it.
Right. Yes, sir.
But they had the authority. I mean, they could have done.
They could have done it, but there was no incentive or requirement that they do it.
I believe that was an issue in Hines County. It's a local contract. They're not paid mutual aid into that petty. This should improve response times. It also will help stabilize systems of care where a county with a heart attack can release an ambulance to take them for the system and have aid to backfill that county. I think this is one of the big issue that MSAC's looking at. But just look, a big part of what I'm seeing with EMS is system error. It's just an old system that's not really meeting the needs of modern day Mississippi, hence studying healthcare comprehensive.
But then you were saying now 1489 makes some revenue available.
Yes,
What's the source of that revenue?
I don't know the exact specifics, but it requires an increase in reimbursement rates from third-party payers for EMS services in general.
They could not even bill for that previously, and now they can, and third-party payers should reimburse.
1489, I think, generates significant improved revenue for the EMS system. Not us, but the system. That's where it needs. And very quickly, the EMS Services Memorial was approved. That's been before the legislature. I know it was last session for sure. But we did push for this, and it was passed and assigned to us to work with the right partners to design and maintain the EMS Memorial. We were given 60,000 to do it. I believe that will be sufficient. And our plan is to redo the front of the campus, and that the memorial will be that area, and it will be done professionally, very respectfully. It'll be high profile. I think it will be a nice, beautiful addition to our campus, and in that we will provide the memorial a very respectful, safe home. Excellent. Okay. Next.
This has to do with just previous ARPA programs that we've had and some new funds that have been appropriated this year. First, the hospital sustainability program was appropriated new funds of $20,435,000 to see there from the general fund for that program. I didn't know if you all had done say anything for me for it.
Yes, Mr. Chairman, I can officially tell you that the hospital sustainability grant is officially completed. It is done and done. Never to speak of it again. But I do want to point out, y'all understand the heavy lift that assignment was for the agency to add the complexities of making ARPA funds work for this. But with Chris and the team's valiant efforts, we were able to get it done. And because of that, over $60 million of federal funds were able to be used rather than state funds. And so instead of $103 million out of capital expense money being used in this fashion, only 20.4 were required. So through the hard work of the agency and our compliance team, we reduced the expense out of the general fund by over $40 million. Well, actually more than $80 million. As you look at the amount of federal funds we were able to deploy and the reduction in state funds that would have gone out under the original bill, that that was the savings of over $80 million, which funds our bucket one or court agency funding that would fund us for 3 years. So I'm very proud of the impact of that work. I'm not sure many agencies can say they saved the general fund $80 million.
Well, not only was it a big headache for us, but it made a significant impact for the struggling hospitals. So this was worth that.
I'm proud that work is completed. I'm proud of what we achieved.
What do we have to spend the rating on for rural water, et cetera?
Everything has to be completed by December 26th.
So, 2024, correct? Or December 26th?
Or 2026. Yeah, that.
So-
So December 2026 is the final deadline.
We have 2.5 years. How much is remaining for the rural water?
We have paid out over 41 million thus far with rural water. Still have a lot to go. And remember, that's a reimbursement model.
Right.
Is this 30 million matching funds or federal funds?
These are the ARPA funds that includes rural water. Yes, sir.
So when we talked about the rural water stuff before, there was a concern about being able to get it all out the door.
Yes.
Because of the reimbursement and eligibility concerns, et cetera. And as I recall, yeah, the wish list was much greater than the available pot of money. They've added 30 million to this with the same restrictions. What do we see as the, and if we need to have this conversation some other time, perfectly fine. I mean, it's 11:36 and we're on agenda item 2. And I worry that whoever's sitting in this room a year and a half from now is going to be having about the same conversations about the rural water program. Just we're going to be substituting rural water for hospital sustainability and getting ahead of it as early as possible would be a good thing.
We've got rural water 1, rural water 2, now, 2A or B, however we want to say it. The 3 different buckets flowing. And of course, that third bucket's brand new. I shared that concern with the appropriation committees on both sides that, this money's not flowing quickly, it's flowing as fast as it can and to maintain compliance. And the programs are as they are now based on what the ARPA compliant team is saying it has to be. So when we get the invoices and they're vetted and appropriate and they're paid and it goes out. But the pain point is that the water associations are having trouble getting the work done. Right. And we can't pay them until the work is done. But I shared with them as they looked at 30B4 coming in that I have great concern we don't get the original money out in time. The work has to be completed by December 26th. So their plan is to keep watching this with us and then make a call in the fall.
So how much total money is still sitting there to be included the 30 million across the 3 bucket?
All right. Well, round 1 was 282 million.
Or spent
41.2, and some of that's round 2. Round 2 was 74.9 million, and then another 28.5 million.
So 300 plus million. Who's running this on a day-to-day basis?
It's like the sustainability grant. Our water team is working with HRK and Horn. And basically their job is to catch those invoices, that and process them and give DFA to pay ones that are appropriate.
I think this is probably another one that's probably worth a specific agenda item. I mean, the idea that we have a $300+ million program that's operating under an unusual set of rules, we've had sort of a demonstrated problem getting it out. And I don't think it's because of anything on our end, but I think that it's probably worth for our next several cycle meetings, a specific agenda item on the board for an update of for barriers, implementation, just running it. Man, I think this deserves a little bit extra attention because this seems like a big flashing red warning sign for the next.
Yes, Dan. Yeah, legislative leadership understands our severe concerns. And I can talk, Chris, we can talk more offline in terms of, are there any statutory opportunities to make it better? Right now, as good as it could be, based on what the experts are telling us, and we'll look to see if there are opportunities in statute.
I think that if we have any ideas, I think you should say to make it work better, it'd be a whole lot easier to do it now as opposed to us getting to summer of 2026 and we have $200 million sitting there. They're about to send back to the federal government.
That's why this observation period this fall is really important. But Mr. Perry, you know how long it took us to get that 20.4 million out of capital expense for the house? But
Well, that was state dollars. So I imagine it took you less than a week.
it was 3 weeks, or So yes, I understand and share your concerns. We'll sure do.
So you'll have that on the October, your state
Yes,
level.
we'll continue to work.
And continue, Logan.
Yes, sir.
Oh, good.
And then we had 2 bills related to the Mississippi Medical Cannabis Program. The first one added federal background check language for the program. It gave the department the authority to charge and retain a fee of $60 per applicant. It authorized the department to recoup any fee associated with the investigation or hearing process. So that was huge to get recoup that authority, because the investigation of the lab at Natchez cost us a lot of money. And I did not have authority with that investigation to recoup the costs from the licensee, but now we do. So, but going forward, as we're hitting those big ticket investigations and we see that the investigation was in fact positive, then we'll recoup the cost of that investigation back into the academy's program budget. And then the thing with the background check fees, it mainly benefits Department of Public Safety, which they needed. It takes an expense item off of them, which is a good thing.
In the final bill,
Then the center, the National Center for Cannabis Research at Ole Miss, I think it's going to be a very good partnership. It's going to help us on the research side, and also vetting all the petitions that I get for new qualifying conditions, looking at the research opportunities, especially as it moves from Schedule 1 to Schedule 3. I think there'll be some really good opportunities for partnership. The only thing that changed with the cannabis program and statute that Logan's I remember was changing the 1 week limit to 30-day limit, so that folks can get a supply that's able to, instead of just 1 week at a time. Okay, perfect. And there was a lot of, Dr. Waits, to your question, a lot of activity related to CON, and the Board of Health recommendations were actually taken up, and legislation was introduced to enact the Board of Health recommendations, and it got way up the road, got to conference committee. But as Dr. Brown said, there are many reasons why bills die, and there was a lot of support for your recommendation. We advocated strongly for it. The only thing that was different from your recommendation is intermediate care facilities were included. We just, that had not been talked about, but, kind of fit into the PRTF situation. They're not the same, but got a similar issues. So that was introduced by committee work. But a lot of very positive feedback on the Board of Health recommendations. I believe it will be taken up again.
and our committee can study this further and make both recommendations.
Yes, sir. And I believe that's, I want to say how proud I am of Logan. He did a great job this session. I believe that our legislators, trust him and depend on him and utilize him a good bit. He does a good job with constituent service work, and also just keeping us all straight during the legislative session. He does a very, very good job of sharing.
Thank you, Logan. We appreciate your good work. Sharon? It's item 3. Hopefully the consent agenda won't have any distractions. Okay.
So this is just that line is right there. That's okay. This is just a high overview of our fiscal year 25 appropriation compared to our fiscal year 24. You'll see that we received about a $9 million increase in general funds and what we call other state support. Other state support is healthcare expendable, tobacco control, and capital expense funds. The majority of that is because we received an additional $6 million related to the trauma care system, about 2.9 related to what we're calling health department programs. Dr. Eddie may want to elaborate on that in a minute, or how he wants to spend some of that funds, and then the Office of Physician Workforce. The federal and other, that is really our ability to spend our federal funds and our fees. So we are really appreciative to get that authority, that they're not giving us any money, it's just the authority to spend what we have. Okay. This is our in addition to money. So you're going to see it out there. Local government Opal Water did receive a large increase in authority. I believe that is because we are anticipating some additional federal funds coming in and some things related to the city of Jackson. Burn care decreased, but that's because we got some one-time money this previous fiscal year. There's special things for two burn care hospitals. And we do not have Sharkey Sequina any longer. That had one-time funding, and medical cannabis went down just a fraction. That's state general funds for medical cannabis. So overall, we came out really well for this session. Next slide. This is how we like to present it in the buckets that you'll hear Dr. Edney speak about. So we try to put everything into things that are core public health, agency internal programs, other purposes, and trauma. So you'll notice the bulk of our money is going out for other purposes. And so really agency is operating at a small number. And I know you like to elaborate on this a lot. You want me to let you talk?
Yeah, and without talking to the the chairs and committees, I try to get their focus on the buckets. Because if you notice, bucket one is core appropriation to run the agency. Bucket two allows its funding for the programs that impact population health issues. And then bucket three are pass-throughs. And so they really don't benefit the agency. Oftentimes it costs us money for us to administer it, to receive it, and pay it out to the person that it's assigned to. So bucket three really is a liability. And helping them understand when they look at that big number, which our appropriation, that is not our money. And then bucket four is the trauma fund. Now the trauma fund, that those of you who served on the board in 2017, is what gutted us. But they moved the trauma fund into our core appropriation, and it wound up knocking the core appropriation down 40%. And the trauma fund kind of covered it up. So I specifically keep that pulled out. And it's important for y'all to understand buckets 1 and 2 are what we're operating on. And I'm very pleased. I've told y'all there's not really any appetite to fund an increase in funding to state agencies. Certainly in Health and Human Services, we got a little bit, like 389, a little less than 400,000 increase of the core appropriation. That'll help us cover some of the increased costs for healthcare, health insurance. So it doesn't cover all of our increased cost. I want to remind y'all, we are a healthcare entity, and the overhead in healthcare has been running 15-20% increased with inflation. It's much worse than just regular inflation. And, that's hit us just like it's hit everybody else in healthcare, but we've had to eat that inflationary cost. But bucket 2 was a huge win. And my focus this session was asking for help in bucket 1, but saying, will you help us attack our current population health crises that we don't have adequate federal funding to work on, such as maternal deaths, such as syphilis, congenital syphilis, such as work on transforming community-based public health, such as standing up, the ability to research comprehensively healthcare. And that's where we got the win. And we got 2.9 million more, and it was given exactly how we asked. It was for, what's the language sharing public health program, health department programs. So that gives us discretion to use that increase. That's one time, and I'm not expecting that to keep happening. I'll have to advocate for it every time. But this year, we're able to use that 2.9 million strategically, how we need to, instead of being directed at us. And that's why we now have adequate funding to fight syphilis. And it's going to really shore up our maternal and death work. And it will be some of our seed money for the state health plan maturity going forward. Building out that office I told you we'll have to build. And then it's, I'll be on Dr. Golson to start getting some grant money. But I was extremely pleased. I'm so grateful that we had that increased appropriation and bucket two. It really allows us to catch our breath. It will be deployed strategically. Their expectation is for me to go back next year, report what we did with it, what it did. And and as I show them a return on this investment, I will ask them for the next round. And we'll go from there.
And another win we had, a small win, the $12 million that we received in state general funds, I'll kind of say it's for both the state money and fiscal year 24, they did not give us any administrative funds for that. Fiscal year 25, they've given us 300,000. So that's a win as well to be able to have administrative costs.
That's a huge win. You know. So what the net positive when we look at the increase in radiation health fees and administrative cost on the state domestic violence shelter grant and increases in buckets 1 and 2 is significant.
And right.
So we're very grateful.
So were you mentioning that 2% that alarm?
This,
Okay, that's all I had unless you have questions.
Any questions for Sherry?
No more question. Our board packet, on the year-to-date expenditures, have that, number as June 4th. The, authority amount, is that an annual amount or is that for the same reporting period through June 4th?
It's been June. That's it, paid the appropriated authority that's for a year. That's for June 30th. And one reason it looks like probably high in comparison to why I should know you're on here for fiscal year 24 is the beginning. During the year, they call it escalate money. And so when you get new grant awards, you're able to increase your authority with the Department of Finance and Administration. So that's the reason the number's a lot higher. And one thing final report up here does not show, this is not included any of the ARPA money, and your ARPA money is included in those sheets and that.
I do want to point out to the public, Mr. Chairman, the significant increase in this appropriation for the trauma fund, which we needed, and we're grateful to get. Excellent.
Okay.
Well, thank you.
Thank you.
All right. Next item on our agenda is our action items. It is a consent agenda. These should be non-controversial. Are there any that you would like to extract or speak to? And if not, is there a motion to approve the consent agenda? Motion and a second. Any further discussion? All in favor, say aye. Aye. Any opposed? All right, got the consent agenda done. Committee reports. Dr. Cheney, would you tell us about the Maternal Infant Health Committee?
Sure. Our most recent maternal health subcommittee meeting was June the 11th. And our primary topic of discussion was the Mississippi Maternal Mortality Review Committee, or the MMRC. As we seek to broaden our knowledge base of what is currently being done in Mississippi to address maternal morbidity and mortality. We did learn that the MMRC is a legislatively mandated multidisciplinary body tasked with reviewing pregnancy-associated deaths for the purpose of proposing actionable recommendations to reduce maternal risks. These recommendations are directed at key stakeholders to inform elected officials, policy advocates, community leaders, medical providers, and the public. The work of the MMRC is funded by the CDC and supported by Mississippi State Department of Health staff. Their most recent report looked at the years 2016 through 2020 and can be seen on the Health Department's website. And I would encourage anybody with any interest in that to look at it. It's a really well done report. This is very important work, and our committee plans to devote our August meeting to a review of the most recent MMRC recommendations and suggest how the Board of Health might act upon these. I just can't say enough about the work that's being done in that, and it's I wouldn't say low-hanging fruit, but they've done so much of the work, and I think we need to partner with them to take their recommendations forward. And so we've learned a lot.
All right, Dr. Cheney, that committee's doing great work. Keep it up. Dr. Carlton, do you have anything from the EMS committee?
Just a few quick things. The primary one I think to think about right now is the recommendation that we change the date of the meetings for EMS Advisory Council. Currently, they meet 2 days after the Board of Health, which means that we don't get their recommendations to act on for basically 3 months. And my recommendation, I've talked to some people in the EMS community and within the EMS committee, I think we should move that in advance of the Board of Health meeting. Obviously, we've got to be in compliance with public comment period, which would move it to the basically 2.5 weeks before the meeting, the Board of Health meeting. But I think there's a lot of frustration in the EMS community with the delays that are just inherent in the system. And I think that would take one point of frustration off the table. And plus it just allows us to act on things faster. Wasn't a whole lot to discuss this time. The consent agenda regarding EMS was just basically housekeeping information that should have been updated probably quite some time ago. I will tell you that next time we will probably have a number of things that we will need to talk about. The transport to other destinations is still something in the works, and it's going to require probably individualization by service or county. And so it's going to be up to the local medical directors. I'm just telling you this in advance so that you'll have heard it when we talk about it perhaps next time. And then the one thing I think is a big need for statewide is a PI committee. We have it for trauma, we have it for the cardiac and a number of other areas, but there's not a statewide PI committee for EMS. I think that's something we can stand up fairly easily, but we're not quite there yet. But that's something else I think we'll hopefully be talking about next time.
Both sound like good things. Any questions? The ceiling committee, we're going to have a meeting in August. We'll figure out a day and sort of discuss the ceiling recommendations for the legislature. We'll probably meet with some stakeholders and it'll maybe just a thinking meeting. Dr. Edney, as far as CON, there are was House that set up a task force to kind of study the issue as well.
Well, they have a hearing next month and from the House side. That's it.
So that's going to be an evolving issue, and that committee will look at that. So we'll plan a meeting in August of that, but be paying attention just for announcements about that. Dr. Anthony, the nominating committee will meet before the next October meeting for your annual recommendation.
Yes, the report read before the October. We'll have a recommendation.
I thought that the turnover was July 1. Well, the bylaws they like us to vote annually. So we should have done it today, but we need a recommendation from the nominating committee. We'll do it in October. When is your term date? The
2027.
yes, until new officers are elected, is my understanding. Well, that's still we let you to 1 year terms though, right? So, well, would there be a recommendation to continue the current set of officers?
Your first question is like, when did your term expire? Like, is it June 30th or is it December 31st?
Well, I do not know.
We got all of that.
This is not from the Bible.
We usually the nomination committee meets in we probably should handle it in April, so and it just with everything going on that's overlooked. So
good. But I thought it was a fiscal year term. So
I think I do not know. if I tell you what I thought with the bylaws, Dr. Eddie will look at the bylaws. Because I know that, as I recall, like and that up here, it's a 1 year term, and without the bylaws, you can serve three terms, right? And are you in your first or are you in your second?
Yes. Opinion.
That's it.
Minutes.
Wait. Dr. Anthony, any, do you know anything about the bylaws that,
Well, no, it's in the first. We're in the first now. So, we are running a little bit, but we can handle that. It was like you.
With Dr. Barnes' death, we got an office leak, and then with COVID also, we got.
Every single meeting, it's something.
Oh, yeah.
so we'll figure it out by the nominating committee. If at the nominating committee, we need to have a special meeting or something. Figure that out.
We'll have the bylaws there too.
But I think what, yeah,
That just to satisfy any issues, the board has the authority to continue leadership as is until the next phase.
Okay.
Should they choose to do this.
so just want to make sure that you are duly elected. Yes. But it is the will of the board that we just will continue the current officers until the nomination committee meets. Good. All right, and I think that will accomplish our bylaws issue. All right, and I apologize that was missed in the hygiene. All right, those are all our committees. Yes,
I do have a
Dr.
question.
Waits.
Jeannie, so your MMRC committee, that's not the health department committee.
Correct. Yeah, it's administratively, they're members of the health department that help with the administration of the committee, but it's not actually a committee.
It's not the task force that you're,
Is right. That way it's legislatively mandated appointment. And I agree that stands independently under the administration of the health department.
right. And then separately, we have a task force or a work group that you're a chair on.
That's committee, subcommittee of the board. Okay, that's Shady's committee. Right. Yes, sir.
Very good. All right. Those are all the committee reports. We're up to new business. Dr. Edney, were we going to get Sharon to come talk to us about the 2% progression or?
I can handle it.
All right.
Very quickly. The legislature in the variable compensation plan this year is allowing a 2% across the board increase for state employees, should state agencies choose to adopt that. And we've looked at it extensively. I think that we need to be investing in our workforce. We have over 1,700 public health workers out in the field all over the state. Many of them were undercompensated. So, but this does not happen very often. The legislature allows across the board. I think we should take advantage of it. We're able to fund it. I believe we likely at the end of the day we'll be able to fund it with even more federal funds. But we will have no difficulty funding this 2% progression agency-wide. It would be available for everyone unless they are already maxed out SEC squared. If they're already above 10% market, then we can't go any higher. And they also changed airline adjustments from 10% down to 7%. This 2% would apply. So through the year, no one would be able to get more than a 5% in addition to this, should we adopt this. And we have, it doesn't require board action to do it, but I do think, with a $2.5 million new expenditure, that was something I preferred to bring.
I think it's important for the board to endorse.
Yes.
And it certainly,
Yes, sir.
and we've often discussed about somebody, look, our employees do a lot of hard work for very low amounts, and our ability to retain them often is difficult in what they're paid. So this would help with retention. It would help with morale.
Yes, sir.
And it's doable, and a lot of the increase probably can be accomplished with federal funds.
Yes, sir.
What other questions do we have about this? is there a motion to, support Dr. Edney's, recommendation that, we do the 2% progression? Has a second. Is there any further discussion? All in favor, say aye. Any opposed? Excellent. Old business. I don't have any old business on there. Do y'all have any? Right. Nothing else. Executive session, there is a personnel matter that needs to be discussed. But that's our last item, for public session. Mr. Moody? So he has moved that we go into closed session to consider executive session. It's a personnel matter, so we'll be going into executive session. All right, no action was taken in executive session. Our next meeting is October 9th. You see our other meetings there. The January 8th meeting, we may have a development session earlier that day, so we may start earlier. So do remember that January meeting. Coffee mugs, if they would like to take one home, you could take your coffee mug home.
They're not used.
Vitamins. Lunch, I think it's from Primo's is upstairs. And with that, is there a motion to adjourn? All right, the deed is done.